While not all healthcare workers and practitioners may be aware of it, CT scans do, in fact, use x-rays. We don't use magnets or death rays, but we definitely use x-rays. And so as a CT
No death
technologist,
rays,
it
you're
is
making
important
that.
to understand radiographic physics in the context of CT. As it turns out, a CT x-ray tube is actually very similar to a traditional x-ray tube. As with traditional radiography, x-rays require three specific conditions to be produced: a source of electrons, a means of rapidly accelerating those electrons or energizing them, and then finally a means of rapidly decelerating those.
Here's the 1, 2, 3s of X-ray. We need a source of electrons. We need the means of rapidly accelerating those electrons. And then we need to abruptly stop those electrons. We need a source of electrons. We need to speed those babies up. And then we need to stop them abruptly. 1, 2, 3. All of this happens in the tube. All of this happens in the tube. All of this happens inside of the tube.
Those electrons, and through the release of that energy, x-rays are produced. All three conditions of x-ray production are taking place in a controlled fashion inside of the x-ray tube. The cathode filament serves as the source of electrons, the rotating anode is the target of the electron stream, and the accelerated electrons will collide with the tungsten target and release their energy in the form of heat and x-rays. And of course, this entire x-ray assembly is encased inside of a vacuum-sealed envelope to maintain the high efficiency needs of x-ray production. So how exactly are CT x-ray tubes different from normal x-ray tubes? Many CT procedures require a continuous x-ray exposure which may last for several seconds. As a result of this, a significant amount of heat is produced inside of the x-ray tube during a CT scan.
So, one source of electrons comes from what side of the X-ray tube? Cathode. Electrons are rapidly moving over to the energized what side of the X-ray tube? Anode. And once they collide with the track, the anode track, right, because it's spinning, what is being released after those electrons abruptly stop?
Heat.
Heat is the number one thing, so we are in the work of what? X-rays. So two things are released, two types of energies are released in the form of heat, thermal, and quantum, or X-ray. Now, he said something very, very vital. Why is X-ray a less radiation dose than CT? He just said it. Caught it. Yes, ma'am.
It sounded like CT is more just a continuous where we just kind of click the button and we're done.
Continuous. What is continuous? What is happening in order to say the word continuous?
It's basically not letting go off the button. They're just,
It's
where
an
they are,
X-ray
yeah,
tech,
they're
we're
holding
thinking
the
they're
button.
on the button.
Yeah, on the button. Yeah.
But this is a protocol. When you get into CT, you click a button and it keeps going. It does it on its own. We're not holding on to that press button. But what is happening continuous? Like I know it. It's right here. Like right there. Where is it? What is continuous? Very good. Very good. The continuous scanning. Because it's a continuous scan, helical or spiral scan around the patient. It has to go all the way around them for whatever your scanning region is, and it is going to produce that much x-rays. So the difference between an x-ray tube and a CT x-ray tube, a static versus a continuous CT, is the continuous scanning time. So it's all time, right? Because when we do x-rays with breathing technique, we increase the time, right? Remember those wonderful math formulas that you guys did? Nightmares for some? Great enthusiasm from your teacher over there for others? It gets excited. That's what we're gonna go back to. We're gonna talk about MA times time, okay? So we definitely have to take into consideration radiation dose, because we know with the continuous scanning time, there is continual release of the x-rays, there is continuous electron source, electron rapidly streaming through, and then abruptly stopping that. All of that is transpiring over a set amount of time. Got it? But has that time decreased with the generations of CT tubes? Why? You're saying yes, but why?
More detectors and the fan beam?
What was the generation number one? How did it acquire its information?
Rotate, translate.
What was it?
Is it translate, rotate?
Translate, rotate, translate. It wasn't continuous. It shifted degree, and it went, right? So we can definitely see.
CT tubes will accommodate this additional heat need
All of
with
these are coming together.
thicker anodes, faster rotating anodes, and a unique tungsten alloy with higher heat capacity and faster cooling rates.
Those are how the characteristics of how a CT tube is different than an X-ray tube. Has to have a thicker anode. Because we know that a constant, as we sit on that X-ray tube and we are pressing that button, we know that we can eventually cause some type of pitting on the anode, and if we pit on the anode because we've had too much energy onto it, it is going to what? Break the tube. Can't replace the anode, you gotta replace the whole entire thing. So we prepare for the more amount of electrons that are going to bombard off of the anode because of the continual scanning, and it's going to be a thicker anode. Faster rotation. Why is that important? The faster the anode rotates, the more it dissipates heat around the tube, right? So it's faster rotation over the X-ray tube. And then the last but not least, we have some elements in there on the tungsten. There's an alloy mix that is going to have a higher heat capacity so that we don't burn out our tungsten coil. Or our focal trap. Alright. Are we good so far? Kind of coming back a little bit? Is it trickling in? Yes? Some of you are convinced?
So what about the X-ray beam of a CT tube? Well, fortunately, the language that's used is very much the same. X-ray photons produced during the CT scan can be defined in terms of intensity and energy, both of which have a very meaningful effect on the patient dose and image quality. Intensity refers to the number of X-ray photons produced in the beam. It's also
number, quantity. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Quantity. How many photons are in this X-ray beam? Make sense? I'm just using a very simple symbol right here of every photon leaving the X-ray tube, reaching. So 1, 2, 3, that means intensity. Intensity is synonymous with quantity. An intense group of bumblebees, they're all coming at you, right? That's intensity. Higher in quantity, right? How many of you are allergic to bumblebees? How many of you just don't want to get stung by a bumblebee? How fast are you running away from a horde of bumblebees as opposed to one? You're like, eh. But if you got a whole horde coming after you, you're running and you're taking off, right? So, that's intensity, it's intense, it's quantity driven. Are we good? Because I'm gonna use that word a lot, intensity, quantity.
Called X-ray quantity. The X-ray energy during the exposure is referring to the energy of the photons, sometimes called quality, hardness, or penetrability. As the energy of the X-ray photons increase, the penetrability of those X-ray photons also increase. Another thing that's also very similar is the X-ray exposure factors for a CT scan. Another
Alright. We have three energies up here, but this just basically means energy equals quality, or energy references hardness, or energy talks about penetrability. Is that a word? Yes.
What's hardness again?
Hardness is going to be, I'm gonna get to it, how can it penetrate?
Okay.
Now, remember when I gave you the example, what kV do you use for a hand? 50. What kVp do you use for an abdomen? 80. Let's just go 80. 75, 80. So you can go anywhere between 75 to 90. 90 is kind of iffy, right? You're burning through. kVp is about the energy. kVp is about the energy, the quality of the beam. As I mentioned earlier, what's the difference between this energy and this energy? Go ahead, Lexus.
The person's higher than
This one has a higher energy. Why? Because we see some crests that are very close together, right? So we know that this energy of this wave is higher than this one. Our crest higher. This is a longer wavelength, right? So they're not as close. So we know that the energy is lower. We're only talking about energy. Now, if I have a piece of bone, I'm gonna try to do a bone. This is a bone. Okay, just make it so. If this energy is aiming at this bone, which one is likely to pass through the bone? The first one or the second one? The first one. It has a higher punch. It has a higher energy. The lower one, or the one that the waves are, the crests are not close together, has a lower energy. It's likely to get absorbed. This one is going to penetrate. If it penetrates through and gets to the detector, there's going to be a value assigned to it, right? Based on the energy that's left in the remnant beam. What's a remnant beam again? It's the X-ray beam that after the patient, right? Passes, exit radiation past the patient. So Angelica asked about energy, penetrate, hardness. The harder the beam, the more it has the opportunity to penetrate through anything. This is why we don't go above 125 kVp. Not likely. Has anyone gone above 125 kVp? You'd go over 125? Oh,
Bariatric.
do you go, that's a good question. Do you go because of adipose over 125 kVp, or do you just up your mass?
Kind of both a little
Both?
bit, yeah.
Okay. I know we don't go past 150.
Oh, no.
Nobody's gone over 150. Because anything that we are aiming at, once you get to 150 kVp, you're going to create, every tissue is going to look similar. You're not creating differentiation, you're creating homogeny. Because the energy, higher the energy is going to penetrate everything, give a value onto the detector, and it's just going to eventually be black. Or one color. Does that make sense? So there's a combination of saying, so when we think about intensity or quantity, it's how many photons are in this beam. and that's regulated by MA and time, right? Energy is the quality of that beam. How hard is it? Is it gonna penetrate what I need it to penetrate? Is it not going to penetrate what I need it to penetrate? So the quality of the beam is, how strong is that beam? How weak is that beam? And you're gonna see that our KVP is the one that makes those differences. MA and time are going to control quantity or intensity. Alright, we good? Yes? Coming back? Alright.
Thing that's also very similar is the X-ray exposure factors for a CT scan. The energy and intensity of the X-ray beam is controlled by the technologist using the MA, the rotation time, and the kilovoltage potential, all of which are very similar to traditional radiography. Let's begin by talking about milliamperage. Milliamperage, also called MA, is a setting which specifically controls the number of X-rays flowing from the X-ray tube per second. Basically, the MA controls the intensity of the X-ray beam. And so changes in the MA have important and predictable effects. If we increase the MA, that also increases the tube intensity, it increases the dose to the patient, and increasing MA will also increase the exposure to the receptor.
So, in the 3 steps to create X-rays, or convert to X-rays, we can't go law of physics, I can hear Mr. Fun in my ear. Can create, okay, convert it. What's number 1? You said it, Nancy. Source of electrons. Step number 2 is to accelerate them, but we're gonna stop at number 1. How do we know how many electrons we need to get? Because we know the more electrons that are in that electron stream that goes over to the anode, the more photons are going to be created or converted, sorry. So it goes back to the source up, and it starts at the cathode, right? In order to increase the intensity, which is another word for what? What's another word for intensity? Quantity of photons, right? We must increase our MA. We increase our MA, we increase our electrons, boiling off. We increase the quantity of those electrons moving over and then having the ability to become photons. Yes, this also contributes to dose because we're putting more photons through that patient, right? Therefore giving it more opportunity to interact within the body or attenuate through the body, right? And then you also increase the exposure. Exposure is related to the detector. Exposure is related to the detector. Exposure, the word exposure is to the detector, not to the patient. The patient is increased dose. Dose to the patient, exposure to the detector. Dose to the patient, exposure to the detector. The exposure to the detector is increased when what value, what technical value is increased? MA, I know, it's right there, MA. It's just switching over the questions. It's just rearranging what I just said. The exposure increases when the MA increases. The quantity of electron increases when what increases? MA. The hardness of a beam increases when what increases? KVP. The exposure increases when what technical value is increased? MA. It's all right here. Okay? So to the detector, to the patient, this is talking about intensity, aka what, Romer? Intensity is AKA, or also known as? Do we need to stretch? What's happening?
The reverse
Right
is
already?
also true. If we decrease the MA during a CT exposure, that will decrease the intensity of the X-ray beam, it will decrease the dose to the patient, and it will also decrease the exposure to the detectors. One way that MA is controlled during a scan is an approach called variable MA. In many cases, we might select a fixed MA so that the entire scan is being performed with the same milliamperage. But a preferred approach is to vary the MA based on the thickness or density of the anatomical section being scanned. For example, in this image of a patient's abdomen, this is the lateral localizer image that the technologist uses to set the boundaries of the abdominal and pelvic scan. But this image is actually overlaid with that dotted line that shows us the MA setting that's going to be used for that section during the scan. And so the MA is actually lowest through the lung fields and highest through the central abdomen and the bony pelvis. This makes sense because the lungs have the lowest density and the abdomen and pelvis have the highest density. These changes are
What does he mean by the abdomen has the highest density? And the pelvis has the highest density? Angelica, I see your mouth moving, I can't hear you if you're saying it to me.
The bone and the tissue is more compact, more dense.
As opposed to the lungs, why the lungs? Why does that have the lowest MA?
Air.
Because of what?
Air.
They're spaced out, right? Very thin tissue. Very easy to penetrate tissue, right? Perfect. I think it's coming together, guys. Yeah? Lexus is giving me the nod of affirmation. I will take
are valuable
it at
for
7
controlling
of
the
5.
patient's dose, keeping the MA lower in the least dense areas and only increasing the MA for the highest density.
Why is this important, a variable MA?
Because of the different density.
Because of the different densities, and that's awesome. But why not just keep it all at this level, up there? Why can't we just do that? We're gonna capture it.
You the
What's the number one thing that we are saving or helping by having a variable MA?
to get the contrast.
Not contrast.
Different shades of green.
Dun, dun, dun.
Yeah. She means it's like penetrating the tissues at different intensities to kind of get the image, or
Intensities?
Yeah.
Okay, that's MA, yes.
Yeah.
The reason why we don't keep it all high,
No.
the reason why we have it at a variable is the lower the MA, the lower the dose. The higher the MA, the higher the dose. We already have a high dose as compared to X-ray. CT is always going to be compared to static imaging X-ray because of the amount of rotation time, the continuous scanning time. So we already have a high time. We have to now take into consideration lowering our MA so that we can try to minimize patient dose. Good. Alright.
That section during the scan. And so the MA is actually lowest through the lung fields and highest through the central abdomen and the bony pelvis. This makes sense because the lungs have the lowest density and the abdomen and pelvis have the highest density. These changes are valuable for controlling the patient's dose, keeping the MA lower in the least dense areas and only increasing the MA for the highest density areas. And so that's how MA can be controlled during a scan. The second exposure factor is rotation time. Unlike general radiography, the technologist does not set the total exposure time, but instead sets the rotation time. Rotation time is simply defined as the total amount of time required for one full rotation of the X-ray tube around the patient. And generally in CT, that's going to be between 0.2 and 1 seconds. So how does changes in rotation time affect the patient and the image? If we increase the rotation time, it has the same effect as increasing the MA. Increasing the rotation time increases the intensity, it increases the dose to the patient, and it increases the exposure to the detectors. But there is one negative effect of increasing.
I'll let her capture that. Am I that loud now? What time I was starting? But those videos of me, Samantha, they're not going out to anyone, are they?
They're going out to us, so they're like on our kind of own
Stays in- What happens
playlist.
in this room stays in this room.
Oh, yeah.
Sounds like he's preaching.
You know,
I'm telling you, it's in the heart.
Whenever y'all were in
He's
school,
he's
they
got
used to come over
physics in the
and
heart.
Sana would be like, "Hey, you're loud over here." Girl, sometimes I would just bang. You're like,
he always used to come to class after his Wednesdays. We were just talking about it. Course, he'd always, you know, he feels that he has to talk that loud so he can keep them awake. That's what he's. That's what he used to tell
You
us.
know, that people used to say to me, you know, what is it? You know, because I call it carbohydrate. If people went to lunch, they'd come back carbohydrate, and I can't handle that. So no faculty wanted the afternoon class. None of us. We used to fight for it. But I had one student. She would follow me. We would fall asleep, right? So she would fall asleep, and she'd be like, "It's your smooth, jazzy voice." I'm like, whatever. I'm gonna be calling your name a lot more in my smooth, jazzy voice. No, it's music. Just let me make me laugh, and I'm like, oh my god, that's funny. But then I had some great stories. So. We're good? So we understand this. So now we're talking about the same thing. Because what is MA times time? Mass, right? So we know that the rotational time will eventually contribute to the overall mass of the exam, right? Time, seconds, because this is all in seconds, right? We talked about a fraction of a second. Second is the unit of measure that we're going to be talking about to reference time. Increased rotation time, increase means a higher volume of electrons are being boiled off. More electrons means more photons, right? Increased dose, which we know more photons in the body. We have now exposed the patient to more of a higher dose. And then what does increased exposure mean, James? This is in reference to the patient?
No, sir, second.
Thank you.
I have a question.
Detectors, yes.
I have a scenario question I've seen in clinic where I've seen techs use for chest x-ray no grade 90 at 1.8 for skinnier patients and bigger patients like 85.
Without a grid?
Without a grid.
Yeah.
So I was curious, what was I trying to say? KVU close up for tissue differences, but they bring the mass down. I forgot the reason.
Because when you have a higher KVP, you're also contributing to the photon exposure or the photon quantity and the dose to the patient. So a higher KVP with a high mass, you're just gonna burn through that tissue. So one goes up, the other one goes down to kind of stabilize that, but the increase in quantity. We know that KVP is going to be the energy, it contributes to the energy, but the higher up to a certain level of KVP, you're going to produce more photons in the primary beam. So the higher the KVP and you don't lower that mass, you're going to have an overexposure by not doing that. But usually without the grid, and so now with everything being digital, it corrects it. I would be curious to see what the exposure value was on the receptor to see if that patient received if it's an overexposed image or if it's an underexposed image based on the S values or the values that's used, the exposure values. Cause no matter what you use now, pretty much, as long as it's able to detect some type of value on the image receptor or on the detector, it's going to quantify, and then it's gonna correct with the histogram analysis. So that's the digital prettiness, but I'll be curious to see what the exposure value of the detector is going to say that it received over the amount or under the amount.
It's usually around 1,500.
For which
Oh, I'm sorry.
machines?
For like the care stream portables, like the 85B.2 for our patient, it's usually around 1,500.
1,500, so that means then you're using pretty standardized technical values. So you're saying, they're saying the same technical values over and over again. The only reason why it would change is patient body habitus or patient size. Awesome. You see, this is why we can go into sales, because we know how to work the machines and then what to expect on the outside. So for those that, I've seen a lot of people go into sales.
Of increasing the rotation time. If we increase the rotation time, that has the potential to decrease the resolution of the
Ooh,
image,
another word.
because increasing rotation time allows for patient movement during the scan. When we combine
I'm gonna go back. We're getting deep, y'all. We're talking resolution. What does resolution mean?
The quality of the image.
The quality of the image. The ability to see the anatomical structures with clarity. The ability to see the anatomical structures with clarity. That's what resolution is. And I said it, I don't know when, like, how many class periods is this? 3, right?
2.
2?
Well, 3 count clinic.
Count what day?
Count clinic.
Is this not our 3rd class day?
Oh, you mean our actual class? I think like a number of classes.
Yeah, I get lost in translation too, so no worries. I'm like, I don't know where I'm at. I hardly know what day I'm
Just the
in.
quality of the
Alexis
image.
and Marquita will tell you, I got a lot going on. I'm not ignoring you. I hope everything is good. I check in on you virtually. Resolution is going to be the anatomical structures, but when we go back, and this is how I've always described it to the students' classes, how do we meet the radiologist? How are we partnering with them, and where do we meet them at? Do you remember when I used to say that in class? Where do we meet them at? My heart.
I'm sorry.
It's supposed to be everlasting. Where do we meet the radiologist at? I know I've said it in 1 or 2 or 3 classes, not this one, not today. I know that much. Where do we meet them at? In step 1, step 2, or step 3 of the CT process? 3. What's in step 3? The image display. This is where the radiologist and I, or us, are going to be one. At the image. What is our role in contributing to that partnership at the image display? The what? The image. What about the image?
Sending it or transferring it to fax or communicating it.
I like it, but before we transfer it, what about the image? You need what?
Reconstruction.
I like the reconstruction. We have different views to present to the radiologist. But what's important about the image?
What is it? The quality of
Yeah,
it?
the highest quality possible.
Optimal.
Best quality possible image. That is going to be, in a nutshell, resolution. We're going to talk about spatial resolution. We're going to talk about contrast resolution. But all of the resolutions, whether we're talking spatial or contrast, is going to go and contribute to diagnostic efficacy. What was diagnostic efficacy? I know I've said those words. The ability to go back and look at those images and interpret and provide a diagnosis. Why do people come to the hospital? Why do people go seek intervention? Why do people get contrast examinations? We are investigators. There is an investigation going on. What's happening with this patient? What medical interventions are needed for this patient? Send them to X-ray. Our jobs are to provide quality care to the patients, number one, and two, quality what? Images. This is how we meet the radiologist halfway. They cannot do their jobs if we do not do ours. So when we think about all of the variables and technical variables that we're responsible for to create an image of high quality, or this word resolution, whether in spatial or contrast we're gonna talk about, is gonna be dependent on what variables we set. Increased time, we know is going to decrease resolution, so that's a no-no, right? Resolution is all it's supposed to be about. We don't wanna increase dose. See me? Sound. I'm gonna go with the sound. That's hilarious. They're awake now, all of them, because we're awake. Alright, so, increase time. Okay, we'll pause.
Somebody doing opera in there?
You gotta see it.
What is going on in there?
I gotta go to the restroom. I'm gonna pee real quick.
Can you get by?
Point it that way so you can hear it.
What is that him doing it?
No, it's
You too? Okay. Dude, I think she does a pretty good job, but I feel kind of, I keep it going. I mean, without doing Mr. Fung's yelling in there, I mean, she does a pretty good job. Yeah.
No, I used to say or, you said or.
Man, at least I know now. When he used to come to class, man, he used to barely, you know, my Wednesday, and he used to say it, my Wednesdays, oh, I have to talk really loud at the fellows. He needs to stop. He does not need to talk loud.
You didn't hear me knocking. Okay, alright, that was fun. So funny. Okay, where was I? What was I saying? What boring stuff was I saying? Diagnostic efficacy. What is it? The ability to make diagnosis from what? The images. Don't forget the images, right? So the radiologists are relying on us to do what? Quality image.
It just brings me back to COVID. Because it was horrible. And we
Yes.
were not doing, because they were making us doing portables in the cords, like TB chest x-ray on portables, spies on portables. And those images were not good.
Not the greatest.
No, it was horrible.
I bet.
I remember it was.
Did you need grids for a lot of that?
Yeah, but even with the grids, it was
Yeah. And then you go back to saying, okay, why did you do it?
well,
Because the benefits outweigh the risks. Why did the benefits outweigh the risks? You went from portable to portable. You went from room to room. You didn't bring patients together. Probably they couldn't even come down. But during COVID, what was the big criteria? Isolation and space. Couldn't violate those things. So you adapted. Quality didn't.
yeah, we just always.
Now somebody said, you know what? Instead of doing that technique, try this technique and it comes out clearer. That's how it starts to continue to move forward. Because those vet techs, they're like, no, this is what you do. And you're like, you see? Oh, they look at the patient. Now you can shoot it. And it comes out better because they're taking into just experience. But that's awesome. It's raining outside, guys. That's what you hear.
Increasing rotation time allows for patient movement during the scan. When we combine MA and rotation time together, we get another technical factor that we refer to as mass, the milliamperage seconds. And just like general radiography, the mass is equal to the MA multiplied by the rotation time. And there is a reciprocal relationship between MA and time. If the rotation time is reduced by half, then the MA must be double to retain the same photon intensity. And so what this means is multiple MA and exposure time settings can result in the same total mass. For example, 50 MA multiplied by 0.6 seconds equals 30 mass. 100 MA times 0.3 seconds also equals 30 mass. And 200 MA times 0.15 seconds also equals 30 mass.
I can see there, we're not ready for math. We're not ready for math. Math, no bueno. All this is basically saying, and I can't tell you how much math is going to be a part of it. I don't see that a lot, and if it is, it's going to be very something simple like this. You increase MA, you have to lower time. If you increase time, you have to lower MA. Those are, one goes up, the other one must come down in order to stay balanced. If you increase one and don't decrease the other, what happens to mass?
Can you say that again? I'm sorry.
If you increase MA but do not adjust your seconds, what happens to mass?
It goes
This goes high.
higher.
Because if you increase one and don't decrease the other, you're going to have a higher mass with the increase. So here, what happens, when mass goes up, patient dose goes up. When mass goes up, patient dose goes up. When mass goes up, patient dose goes up. So in order to control patient dose, we must manipulate these factors. Do we want more electrons? Or do we need more time to rotate around the patient? Do we need more electrons, more photons in the mix? Or do we need more time? Either one, if the answer is yes, if you do not adjust the other, the mass will increase. So let's take an experiment. Multiply 200 times 2. 400 times 0.15 seconds. You can take out your calculators. So we multiply 200 by 2. We got 400. We multiplied it by 1.5 seconds, or just 1.5. Did we have 30 as your final answer?
Yeah.
No, what is it? 60? Because we doubled the MA and we did not reduce this by half. So did we increase the mass when we increased the MA or the time? Did mass increase? And what does mass contribute? Patient dose. Now, y'all ready? Are you ready? If I leave MA alone, but I increase my time by 2, so now we have what? 0.15 times 2 is? 30? Okay. And we multiply that, we know that mass is going to go up. But when we increase time, and we make whatever adjustments over here, I'm not worried about mass. Do we increase resolution?
No, you increase it.
You decrease resolution. So mixing these variables will not always produce the same effect. So when you're thinking about questions, think about what it's asking you. Resolution, dose. Exposure, intensity. Hardness, energy. So all those words mean something. So it's terminology. Make sure that you know or understand your terminology and what it's relating to. Got it? Because we can increase MA and we didn't lose resolution. Does that make sense? But if we increase time, it impacts our resolution. Good stuff. I know it.
So let's look at an example of how we can use this in practice. Here's a case study. A CT of the head without contrast is requested on an infant. The infant is non-compliant as expected, and the first scan is completely non-diagnostic due to motion. Motion artifact can of course be reduced by a
Non-diagnostic, is that diagnostic efficacy? I see some no's. Non-diagnostic, does that mean it has high diagnostic efficacy? No, because diagnostic efficacy means what? The ability, the clarity, the quality of the image to make an interpretation, right, instead of diagnosis. If it's non-diagnostic, we did not achieve that. Why did we not achieve that? Because it's an infant, the patient is an infant, and there was a lot of movement.
faster rotation time. So if the rotation time is reduced from 1 second down to 0.5 seconds, how should the MA be adjusted? This is actually a two-step process. First, don't make this mistake in the first place. The case of a wiggling infant is actually a very common problem. It's also a very predictable problem. In a real-life scenario, a good technologist would have recognized the potential for motion artifact and made the technical adjustments on the first attempt. But the solution is very simple. Step 2, the rotation time was reduced by a factor of 2 from 1 to 1/2, and so the MA should be increased by a factor of 2 in order to maintain the same total exposure.
Why was the time halved? Why was the time halved in this scenario?
To reduce motion.
To reduce motion. Okay? So time is a direct contributor to what? Removing any type of what? Artifacts. Motion is considered an artifact, right? But the reduction of time here is not so much for the dose because the dose was maintained to the patient, but it was the ability to increase the resolution. So time was reduced to increase the resolution of the images because the baby was wiggling or the baby was moving. So a faster scan time is the opportunity to reduce those motion artifacts or degrade the image, increase the resolution. Okay? So the questions can come just like that, just think about it through, right? And you're saying, what are these
The last
questions
exposure factor we'll discuss is the kilovoltage peak, or KVP. KVP is the voltage of the X-ray tube, and therefore controls the beam energy. But that's not the only thing it affects. Changes in KVP have a predictable effect on the X-ray beam. If we increase KVP, this will increase the beam energy, but it also increases the beam intensity, which then increases the patient dose and increases the exposure to the receptors. So when
This is what you just asked about, James, right? How can KVP contribute? Because the increased intensity, but increased KVP can also increase, what is intensity AKA for? Quantity of photons being released into that beam.
KVP is increased and no other factors are changed,
Did you capture that before we continue on with the video?
there is an increase in the penetration through the patient, but also an increase in the total number of photons absorbed in the patient. The reverse is also true. If we decrease the KVP, this will decrease the beam energy, but it also decreases the beam intensity, which decreases the patient dose and decreases the exposure to the receptors. Let's look at one more case study to explain how we can use this in practice. A CT of the lower leg is requested on a patient with an infected wound and significant edema, which is swelling. The leg is swollen to 2 to 3 times the normal size. How, if at all, should the exposure factors of the scan be adjusted? This particular case actually has a simple solution. If we're dealing with an increased amount of tissue,
Walk me through, guys. Increased amount of tissue, swelling. Do we need to penetrate more?
Yes.
Because the tissue density is now more, right? Okay.
it would be appropriate to increase the mass in some way, preferably by increasing the MA, or we could increase the KVP. Some protocols at some facilities might actually have a variable MA setting already programmed into the scan. If that's the case, the scanner will recognize the increased thickness of the leg and increase MA accordingly.